It's a pleasure to open the session today here in New York City for SMIC's a place and a meeting that are both dear to my heart. Unfortunately, a good friend, Mark Ruel, is unable to be here today. He's had some transportation challenges and is presently in Ottawa, another nice city, but it's not here. So I was given the task of filling in for Mark 3 minutes ago. And so what I'm going to do is go through his slides rather quickly. This is really meant to be a session in which we want to impart and share our thoughts about what every surgeon should be able to articulate in conversation with cardiologists in a heart team forum about minimally invasive CABG, conventional CABG, and PCI, and the relative indications and merits in different patient subsets. So I'm going to zip through Mark's slides initially and then engage in a conversation with Mario Gaudino, Sam Balki, and Satyaki Nambala from Bangalore, because they each have a different perspective. I don't think anyone knows more about the data than Mario Gaudino. Sam Balki is North America's most skilled robotic surgeon, and Dr. Nambala has had a huge experience in mixed CABG in India, a place where coronary bypass surgery is exploding. Mark Ruel has a particular series of opinions, and we're going to present those to you. These are his cardiologists with whom he has to discuss PCI versus CABG on a regular basis. They don't look like bad people. His emphasis is on the 4 recent papers, XL, Noble, Freedom, and a recent Head Lancet meta-analysis. So briefly, XL randomized almost 2,000 patients. Mark has taken particular issue with the design of the trial, in particular the definition of periprocedural myocardial infarction. And in fairness, this is a corporate-sponsored study sponsored by a stent manufacturer, and claimed non-inferiority of PCI versus CABG for left main and multivessel disease at 3 years. And that was largely because of the definition of myocardial infarction. At 4 years, however, there was a 39% relative increase in mortality in the PCI group compared to CABG. So that was not a pre-specified powered endpoint, but rather just a finding at 4 years. And the curves continued to diverge. The 5-year data will be presented at TCT this year. Subgroup analyses and quality of life claims are relatively weak in Mark's mind. And one of the key features in this trial, I think that they did correctly, was this trial optimized medical management of patients in both limbs. Now, it's important to note that this definition of myocardial infarction used in the XL trial is different from that in the Syntex trial or Freedom trial or Berry trials in the past. And it basically eliminated counting of small troponin leaks in the PCI group. And so only larger leaks ended up being counted, very few of them being in routine PCI, and occasionally one being in a coronary bypass case. Most of these are done on bypass with global myocardial cardioplegia. And so that tended to favor the PCI group, and these were the definitions used, which actually are different from those used previously. This is a very interesting paper that Mark and others published in JACC in 2017, looking at different definitions of CABG versus PCI. And it really matters which definition you use to compare outcomes from PCI versus CABG. There's this thing called the universal definition of myocardial infarction. The third universal definition is the present one, and the SKY definition. You can see the same patient groups being compared by these two definitions yield very different comparisons of incidence of myocardial infarction. And this, of course, drives a composite endpoint, importantly. So the 3-year data for XL looked like a wash. At least the curves are overlapping if you interpret it one way, or they're crossing and then diverging if you interpret another way. As it turns out, at 3 years, the curves continue to diverge. And in fact, at 4 years, there was a mortality benefit for CABG over PCI. Now, Noble was a contemporaneous study of left main patients as well. It went on simultaneous with XL, and actually had the opportunity of discussing the two of them together at TCT with the two primary principal investigators a couple of years ago. Noble enrolled 1,200 patients. They were relatively healthy patients and had few with diabetes. These are Scandinavian patients. And interestingly, the coronary bypass patients outperformed the PCI patients pretty dramatically. So while in XL there was a crossing of the lines at 3 years, in Noble the lines crossed at 1 year and continued to diverge through 5 years of follow-up. There are similar patient populations, at least to the extent that they have all had left main disease. I think very importantly is this paper. This is the Freedom study published by Valentin Fuster and Michael Farku and others. Almost 2,000 patients with diabetes, most of whom had 3-vessel disease, were randomized to have multivessel PCI with contemporaneous stenting or coronary bypass. Mark would call the surgery not done very well. There were, in fact, large geographic variations in outcomes, and there was a relatively high stroke rate, but nonetheless, there was a substantial mortality benefit with CABG over PCI. And that mortality benefit was evident by 5 years. And we've recently seen the 7-year data from this trial, and the curves continue to diverge. The mortality benefit is greater with each year of follow-up. Now, Syntax, as you know, is perhaps, this is more data from the Freedom trial, looking at, in Syntax, the trial Syntax, of course, the Syntax score had a great deal to do with the relative benefit of CABG over PCI. That was not the case among diabetics, and I think this is one of the primary points to discuss, something that we all need to understand. There is something different biologically about patients with diabetes, and their coronary artery disease is subsequently different than patients who do not have diabetes. Among diabetic patients, Syntax score is less important in predicting the relative benefit of CABG over PCI. In general, CABG outperforms PCI in diabetic patients of all 3 terciles of coronary artery disease. And I think that's an important concept. That really didn't come out until just last year with the 7-year data from Freedom and the meta-analysis, or rather the subset analysis presented there. Now, there's this other recent meta-analysis in Lancet just last year, about 12,000 pooled patients, relatively young patients with relatively short 4-year follow-up, still a 20% relative mortality benefit of CABG over PCI. And here's where I think Mario can make some comments. When we see subgroup analysis of underpowered post-hoc comparisons, one has to be very careful about making conclusions. Particularly, it boils down to the concept that absence of evidence is not evidence of absence. Underpowered post-hoc subset analyses claiming that patients only benefit if they have diabetes or high Syntax score may not actually be correct, especially in diabetic patients. And you will note that there's been a plethora of recent publications based on the 3-year data set from XL. Just an armada of publications being launched from this old data set. We now have 5-year data, which shows CABG is substantially superior to PCI. But the authors, funded by Abbott, are publishing one after the other repeated analysis of the old 3-year data set. So I think another key point that we all need to articulate is, frankly, 1, 2, or 3-year follow-up of a CABG versus PCI comparison should be considered interim analysis, largely meaningless, only applicable to patients who have a 3-year or less life expectancy. And in those patients, I think it does make sense to talk about those data. If you've got a 2-year life expectancy, PCI is better than CABG. Let's be straight. If you've got a 10-year life expectancy, PCI is not better than CABG in almost all subgroups of patients. And these are the sort of things we need to be able to articulate. So this is an interesting study, and I'm going to ask Mario to comment on it. The pooling and subgrouping of data from CABG versus PCI trials. I'm not even going to comment on the slide. Mario will ask you later to do that. And to give some insight into why you think XL and Noble are actually consistent with each other. Mark is making a pitch for mix. As you know, that's his favorite operation. This is how he does it. This is an interesting study published by cardiologists analyzing outcomes for quality of life, actually finding it superior after CABG than after PCI in the Freedom trial longer-term follow-up. And you know, early quality of life almost always favors PCI. Patients with PCI like that little wrist Band-Aid or groin Band-Aid. Patients after sternotomy have some discomfort for a period of time. So early comparisons of quality of life in CABG versus PCI almost always favor PCI. And here you see in the Freedom trial, after 2 years, it favors CABG. So here again, quality of life initially favoring PCI, and then over time favoring CABG. So as you know, there are trade-offs in clinical medicine that we face all the time. Many patients, if told that PCI is almost as good as a sternotomy CABG, will choose the PCI, and a lot of that depends on messaging. And so here's Dr. Nambala, a co-author in this paper. We'll ask him to comment on the MIST trial a little later. So I'm going to leave this slide alone from Mark's data set. And he ends with this set of questions. But I'm going to start instead by asking Mario to tell us about those statistical matters that surgeons need to be articulate in. And then Dr. Nambala to discuss that MIST issue. And finally, I want Sam Balke to give us his perspectives as a practitioner of really what is a tiny niche within the field now, and should it and can it grow. So Mario, please add.
Thank you, John, and morning, everybody. So yeah, I will try to be quick. I think the key point that we need to know is that this year the most important piece of evidence showing the better result of CABG compared to PCI has been published, and it is that Lancet meta-analysis that John was alluding to. Is the head meta-analysis, 11,000 patient, 11 randomized trial, a solid benefit in terms of mortality for CABG at 5 years. So this meta-analysis is very important because it's the first time we show a survival benefit. So we are not discussing MACE, we are not discussing freedom from revascularization. It's the first time that CABG is proven to be superior in terms of survival at 5 years, and it's hard to beat better survival. So this is something that must be noted. Now, in the as John was alluding, unfortunately, the other that we must admit were mostly PI funded by industry perform a statistical analysis, which I don't want to bother with the details, but is fundamentally wrong. They use the wrong test. They use the classical p-value instead of the interaction p-value, trying to make the point that in some subgroup, like the patient with low syntax score, this benefit is not true. That's why we felt the need to clarify that in that paper that is published on the European Journal of Cardiothoracic Surgery. And if you use the data of that meta-analysis and you apply the right test, which is the P for interaction, you will see that in all subgroup, the result is consistent with the result of the primary analysis, which means CABG better. So there is no doubt that head meta-analysis, despite what is written in the discussion and in the abstract, is a strong, solid argument in favor of CABG compared to PCI. And this is something that we should quote in every discussion with our cardiologists, keeping in mind the limitation of the subgroup analysis that is published in the Lancet paper. Also, very quick point. Remember, the syntax score is not written in stone. The syntax score has never been validated prospectively. The syntax score is the result of a post-hoc analysis of the syntax trial, has been adopted with enthusiasm by the cardiology community because so that they can do PCI on the low syntax score. There has never been a validation. Most of the post-hoc analysis after syntax did not show a treatment effect correlated to the syntax score. We know that in diabetic we should just ignore it, but even in non-diabetic, it's highly questionable if the syntax score should drive our decision making. And finally, Sam and I was just discussing that I think that as a community we need to understand that we are probably using the wrong outcome to judge the result of our operation. We keep looking at, and this is more for the minimal invasive technique, we keep looking at survival, MI, those very hard endpoints. I think we should not look at quality of life. This is one of the most important reasons why we operate on patients. So far, there has been no trial that has used quality of life as the primary outcome, and so that has been powered to show difference in quality of life. And I think this is something, I mean, moving forward, this is something that we need to keep in mind when we design new trials. Thank you.
Terrific, Mario. Dr. Nambala, tell us about your experience with mixed CABG, and how do you think that expertise impacts the discussion of CABG, mixed CABG versus PCI?
I think mixed CABG probably falls in between PCI and a standard CABG, because from our own experience, what we see is this. If you look at the current subset of patients we operate on, the majority of patients who are referred for a standard CABG are patients with 2 or 3 vessel disease, generally diffuse, poor quality vessels, and these are a very sick subset of patients. And obviously, comparing this subset of patients to PCI is probably not relevant at all, just like Mario said now. Now, what mixed CABG probably does is, like he said, it improves the quality. When you look at the quality of life, it's probably better at that. We still don't know. We're going to do the mixed trial, and we're probably going to know in the next couple of months. But what it has, if you look at it, what it tells us is this: there are a lot of patients who are ready to, who are willing to undergo a PCI against a CABG. I'm talking about patients with multivessel disease, not so discrete lesions, not ideal candidates for PCI, are now willing to undergo a procedure that's less invasive. If you look at the next subset of patients, patients who are suitable for both PCI and CABG as well, that's discrete lesions, good quality vessels, healthier younger patients, a small subset of these patients also might choose mixed CABG. So in the long run, again, we're not talking about 2, 3, or 4 years. If you're talking 10 years, mixed CABG would probably have a bigger role in treating these subsets of patients, and probably a volume of CABG would also go up. I think if you are able to perform a good mixed CABG, multivessel, just like we would do in the open technique, I think minimally invasive is there to stay. And I definitely think it has a larger benefit than open CABG.
So Sam, you are North America's perhaps most prolific practitioner of robotic coronary bypass, and indeed totally endoscopic coronary bypass. How does that change your conversation at a heart team meeting? You work at the University of Chicago. You're the only one doing TCAB there. There are presumably other surgeons doing CABG. You all attend the same heart team meetings together?
Not really.
So you have a sidebar. So there's a sidebar conversation with cardiologists and the TCAB surgeon, and a different conversation that they have with the standard CABG surgeon. How do those two conversations differ?
Yeah. Well, first of all, I want to thank you for presenting that data, because I think it's important for all of us to really get our arms around a lot of the data that's coming out that the cardiologists use every day. And whether it's Noble or it's Excel or more importantly Freedom, I think most surgeons and probably most cardiologists would agree that arterial grafting is the most important thing that comes out of these trials. And multi-arterial grafting in most surgeons' minds is the epitome of that. And the ability to do a multi-vessel, totally arterial bypass graft with the least invasiveness and the least amount of morbidity becomes the pinnacle of what we do. And now that we have really started to focus a little bit more on coronary bypass after the whole stent wave came through, and now we're kind of back. And in addition, the fact that younger surgeons really need to embrace CABG a little bit more with a lot of the things that we do on valves kind of going the percutaneous way, I think it's important for us to really embrace CABG in a new era of how do we do exactly what Mario said. How do we define what our endpoints are? And if our endpoints are going to continue to be death and stroke, we haven't really made any progress. Our endpoints need to be quality of life. And insofar as we can provide an arterial bypass without maximum invasiveness, without cross-clamping the aorta, without opening the sternum and subjecting patients to sternal wound infections, I think we are able to really move forward in this field. And so the conversation that happens in my hospital is very simple. Patients come to my hospital because we offer TCAB. They come not from our cardiologist's cath lab in my hospital. I am a referring physician to my cardiologist because patients come to me with multivessel disease. They have the desire not to have a sternotomy. They come from far away, and I refer them to my cardiologists to try to figure out what the best strategy would be. There are some patients, obviously, that you cannot do a hybrid on, but I think the frontier right now for us in terms of data is what is the role of hybrid revascularization, and John, you're the best person to speak to that and to what the best design of a trial would be in terms of verifying and understanding what the role of hybrid is.
Well, I think we can certainly touch briefly on the role of hybrid. I have always viewed hybrid therapy as a competitor of multivessel stenting. I have never viewed it as a competitor of conventional CABG or OpCab or no aortic touch OpCab. I have rather viewed it as a little bit of a deal with the devil, a compromise that ends up having more patients receive an arterial graft to the LAD than otherwise would be the case. They're otherwise going to have multivessel PCI. And so we designed a trial that compared patients who were eligible for multivessel PCI or hybrid therapy, and we wanted to randomize them. And actually, enrollment was so slow in the United States that the NIH, in its wisdom, pulled the plug on the trial. And so the hybrid trial has been unfunded very recently. Even before we were able to open sites in Europe or Asia, which was another political issue related to the federal funding mechanism and the present political climate in Washington. So we got kind of caught in the, if you will, the crossfire of lack of equipoise in the United States and disappointing enrollment here, and the politics of sending federal tax dollars to Europe and Asia to do research in the present administration in Washington. And then the third thing that got us was that the NIH now has a strict limit that you have to complete enrollment and analysis of all trials within 7 years. Well, if you've got to enroll 2,000 hybrid patients and have a 5-year endpoint, and you get off to a slow start with enrollment, you can't make it in 7 years. So they were right about that one point. The rest of it I took issue with. But long story short, the hybrid trial is not going to happen. We enrolled 200 patients in the United States. They will be followed for 2 years, and that's it. So there is no ongoing randomized or large randomized trial on hybrid. I still view hybrid as an alternative to inappropriate multivessel PCI, and I think it's especially useful in younger patients who at least will get the life-preserving benefit of an internal mammary to the LAD rather than stents in the LAD. I think it will lead to fewer patients with a full metal jacket in the LAD coming for a desperate attempt at endarterectomy or apical LAD grafting in their later 50s or 60s or 70s. So that's my view on hybrid therapy. Whether we could ever get a trial off the ground that enrolled enough patients to prove that benefit is highly doubtful to me. I think it would have to be done on a very small budget by a group of centers that were committed to answering that question. It doesn't have a corporate sponsor willing to spend $80 million, which is what Abbott spent on the XL trial. So I'm castigating them for repeatedly mining the 3-year endpoint data because that makes PCI look equivalent to CABG, and ignoring the 4 and 5 year data, which clearly shows CABG is superior. But they spent $80 million generating that data set. You got to believe they want some money in return for their investment, and they're trying to reap that now. So that's another problem with corporate-sponsored trials. We don't have a new device that generates $1 billion new market like a drug-eluting stent can do. Coronary bypass is a relatively inexpensive procedure from the point of view of disposables and new toys. And I'll say that the only expensive thing that's come along in terms of coronary bypass surgery is the Intuitive robot. And yet the Intuitive is largely backed away from supporting coronary bypass surgery with the robot. They're really a prostate company now. I know some of them are here, but that's just the facts. They're a bunch of urologists who are no longer committed to supporting innovation in cardiac surgery, certainly not in coronary surgery. We'd like to advance the field. And so I'd like to summarize with emphasizing a few points, again, in the theme of what we need to do to inform surgeons to have the right conversations. And I think that the conversations have to center around duration of follow-up. A 1 or 2 or 3 year comparison of CABG versus PCI is irrelevant, except to patients who have a 3-year life expectancy. In patients with diabetes, who are becoming increasingly more common in both the Indian subcontinent and in this continent, syntax score seems to have a substantially lesser role in predicting the relative benefit of CABG over PCI. And indeed, in those patients, most of them will do better with coronary bypass surgery than with multivessel PCI. To Sam's point, multi-arterial grafting is the most important thing that I think we can all do by some technique or another to advance the field of coronary surgery. Whether it's an on-pump, single clamp, full sternotomy operation that gives 2 or 3 arterial grafts every day routinely to our patients, or it's a no aortic touch UpCab, or it's a beta TCAB, it's still better for our patients than a conventional lima and 3 veins by any technique, including a mix. And I think that we need to be emphasizing the relatively longer-term benefit of our operation over the short-term convenience of a PCI. And to me, that means optimizing our long-term outcomes, and that means arterial grafting. We do want to minimize the morbidity up front, especially stroke and sternal wound infections. Right? These are the things that are, other than death, of course, are the morbidities that people are most unhappy with around the time of cardiac surgery. And so I think no aortic touch surgery, minimizing stroke, there's a compelling evidence base to support that. And frankly, avoiding sternotomy or managing sternotomy well in obese diabetic patients, and I'm a big fan just of vancomycin paste in the bone marrow. Do a brief, clean operation. Don't end up transfusing your patients, wash them out well before you close them, and layer vancomycin paste in the bone marrow. Knock on wood, we've done over 500 consecutive CABGs at St. Luke's here in New York without a sternal wound infection, and the vast majority of them have multi-arterial grafting. More than 90% have 2 or more grafts. Finally, I'd like to comment on FFR. This is an important panel of people who have thought a lot about coronary surgery and done a lot of coronary surgery. I think, to be perfectly honest, the next challenge from cardiologists will be the concept that FFR guides best practice in PCI, and therefore it should guide best practice in CABG. First fallacy. That, what I just said, is not proven and not even actually logically true. But if you were to go down that road, as many cardiologists are doing, you would be able to downgrade syntax scores into the lower terciles where PCI by a non-FFR comparison was found to be equivalent. And so I think this is an important concept, one deserving a lot of discussion, and I'd ask Mario to share his thoughts on that.
Thanks, John. So first of all, if syntax score is not validated, FFR-based syntax is even less validated. So just don't buy that. It's not, it is not true. PCI and CABG work in a different way, and the failure of a stent is not the failure of a graft. FFR has probably a role in the indication to which type of arterial conduits you want to use. There are situations where probably a mammary, which is less sensitive to competitive flow, is better than a radial artery, but that has nothing to do with the indication to the type of revascularization the patient needs to have. So John is right. There is this clear attempt by some invasive cardiologists to use FFR to downgrade the patient with 3-vessel disease to 2-vessel disease and so on, and to shift the indication from CABG to PCI, but this is just not validated. I think at the moment FFR is a great tool for conduit selection. This is how I look at it, but has no role in the decision-making for revascularization strategy at present.
We have 30 seconds left. Dr. Nambala?
I really have nothing much to say except for that last question there. Can we afford to take on multivessel mixed CABG? If you can afford to take on multivessel open CABGs, I think you can afford to take on mixed CABGs as well. And I think Dr. Banki would agree with me. I don't know why that question is on there at all.
Sam, you get the last word.
I was thinking maybe a question or comment from the audience if somebody, yeah, Manny had some things to say.
We're in New York City, and Manny Subramania is here, so he should have the last word.
25 years ago, mid-cab here first, 1994. But I will tell you, I think Sam is right. The quality of life is going to be extremely important. When we started doing the mid-cab, I will tell you a fact that I always told the patient we're doing a procedure. I recorded tons of mid-cab patients referred. Jeff Moses got very upset that it is a surgery. So it's a semantics, and basically what we want to call, I think this is how do you solve that, is a big issue. I will tell you, when John, you started off, how do you speak to the public? Let me just tell you, public information is not always public consumption. Mm-hmm. So you can talk all you want, you know. It is about how you message it. I always felt the therapy is regarding the time and the place where you are. Where you are, what part of the globe you are. At that time, stenting was not big, so mid-cab really won. So now I think with all of the advances in stenting, you really have to ask what age you want to have a PCI, what is your life expectancy. The big and unanswered question is, once you have a stent in the LAD, if it closes off, can you have an additional surgery? So that's never been answered. Yep. And for example, I will tell you, I had my stent in the LAD, focal lesion. And FFR was ideal. I had an X-Science shorter stent, 15 millimeter, 2.75. I did that mainly because I felt I'm 80 years old, and I may have a couple of years of life left, but still enjoying. But one thing I observed, this is something very interesting, and the experience was phenomenal, unbelievable. I could not have had my mid-cab or robotic experience because this is unbelievable. Go in the morning and get afternoon. It is the experience is very different. But I will tell you, when I noted the LAD was as thin, but I'm a diabetic, well controlled, around the apex. And as soon as the stent is in, the LAD became so big. I've never seen an LAD as big as even my multiple years of Lima LAD. I don't know why, but the Lima LAD, the LAD is really not as huge as we see in the PCI. Perhaps it may be a flow gradient. I told Sam to do some study. It'll be very interesting. And I think it depends on when you talk to the patients, how you talk to that. Multivessel, definitely you got to have a bypass. And I don't think multivessel PCI, it's not that often done. 75% of the people don't do multivessel PCI interventional. So it's a question of what do you do with a single and the double vessel disease. So that's just my few pearls.
So in response to that, I would comment that I think that we in general, we cardiovascular specialists, do too much PCI in young patients and maybe too much surgery in old patients. I think, oh, he's too young to send to surgery. I think those words should never be uttered, but they're common. Oh, he's a 45-year-old executive with revascularized disease. We'll give him some stents and he'll come back for CABG in 10 years. But he'll come back with a lower ejection fraction in a much more difficult setting. And the alternative of 3 arterial grafts now would likely mean that he never comes back. Rainey.
2 mammaries, 25 years out, no infarct, no stent, still alive.
Attaboy. Great way to end the session. Thank you all very much.
No redo.
No need. Very good.
That was good. It was not selling.
So there's a coffee break now, and we reconvene at 10 a.m. Thank you. No. No. I'm wrong. Sorry. This is what happens when you get a pinch hitter moderator. Our next moderator is Mattia Glauber, and the session is indications for TAVR versus minimally invasive AVR versus sternotomy, which will go on right now. Panelists are Anson Chung, Dominique Rosoli, Joe Lamellis, and Marala Ozulian.
How are you? Fine. Good to see you. Nice moderation. Take it away, buddy. Up there. I don't have slides. I know. Oh, yeah. I see. Have you met the case to go? No. I wasn't asked to. Okay. Someone is missing. Dr. Grisoli?
Supposed to be up here. We could probably get Tom up here. Okay, great.
Sorry, what is it?
Should get closer to the mic.
Okay.
So maybe we could. So I don't see them. Maybe get Tom to come up.
I think we don't have Dr. Grisoli here, so we can perhaps ask Tom to join, seeing that he was part of the organization of this new setup of presentations. And I will start this very interesting topic, very hot. I don't have any slides to present, but I have many questions to pose to our faculty here. Seeing that just last week I met my cardiologist coming back from PCR in Paris, and they were so happy from the last data which were presented there. Quite even provocative, telling me you will see that cardiac surgery will be considered soon malpractice in AVR surgery. So that was surely provocative, but it's what our cardiologists mostly are thinking. So we have a sort of revival from the era of the stent. And we see now, and the discussion of before was really very interesting, showing us that there is sure a more critical view, at least from our point of view, that surgery still play an important role. But the important topics that we have to discuss are surely more interesting, seen that the Evolute trial and the Partner 3 trial in a low-risk group of patients showed us data actually related on the demonstrating the non-inferiority of TAVI. And but I think we still have many questions open on this topic. So I would ask Anson, seeing that he surely is involved in the program of TAVI, what is his vision related to the recent data?
Well, I'm sure you all heard during ACC that 2 major trials came out, Partner 3 and Medtronic low-risk TAVR trial versus surgery, obviously, and showed non-inferiority and also superiority in the Edwards trial, the Partner 3. So to look at those trials, and even Ocean, and also the other lowest trial in Scandinavian country, one of the most important things is to look at those trials, especially for the Edwards trial, is the fundamental design of the trial to bias towards TAVR. The outcome, which is the composite outcome of that trial, is driven by MI, stroke, death, and combined with rehospitalization, which is one of the things that we really never use in looking at the outcome. Maybe it's important as quality of life. That was superior than surgery for that. But if you look at the individual, look at those hard outcomes that we generally look at as surgeons, none of them were superior. So that's one point I would like to emphasize. Second is that I think that is the low risk. What is really low risk? If you look at the average age of patient in those trials, in PARTNER is 75 around, and then same as Medtronic. In the Notion trial, 79 years old. So they may be low risk by the standard STS score risk calculation, but they're still old patients. So I think one of the things is that the messaging, of course the public doesn't understand that. The public understand, well, I'm low risk, I should get a TAVR. They're pushing for it, and of course the company would like to see that to increase their profit. For us to actually go out, we have to say that, well, in younger patient, that low risk does not equal to an 80-year-old low risk patient. The young patient have a complete different set of requirement, things that we don't know about. For instance, a long-term risk and effect of a pacemaker, which in TAVR obviously is much higher than surgical aortic valve. Second, per-valve leak. And third, durability of the TAVR valve versus a surgical valve. Though, we've been at it since 2005, we're doing TAVR. And if you look at the older patient, we have not seen any differences in terms of durability. For younger patient, you might actually start to see that. So those are very many unanswered questions, but I think the things that to do is obviously long-term follow-up of those trials, and then messaging, and also to educate your patient, cardiologist, and many administrator to not to just blindly trust those trials and have to really further dissect it.
I'll add a couple other points about how the trials are biased a little bit towards TAVR. If you look at the studies carefully, roughly 23-24% of the SAVR arm had concomitant procedures, and about maybe 7 or 8% of TAVR had concomitant procedures. And in that light, if you're looking at the endpoints being readmission, then certainly a SAVR, CABG, SAVR, MVR, et cetera, is going to have a higher readmission rate and potentially a higher potential complication rate than a TAVR one-vessel PCI. And that's really important. But the writing's on the wall at the end of the day, right? We're not going to be able to fight this, and TAVR is here to stay. And it's going to be approved for patients who are low risk. And I think as much as we kind of bring up these contention points, it's not going anywhere. And we're going to see it approved by the FDA pretty soon. And my stance, and I see a lot of other colleagues out in the audience as well, Rosh and Gilbert, is that in many ways we need to adopt and embrace this technology because it's not going anywhere. We did, right after this study was presented at the ACC, and I was there, I came back to the mini AVR in a patient. The very first thing the cardiologist said was, why did this patient get a TAVR? So we're getting to the point now, I'm sure, that you might have to justify doing SAVRs on patients. I'm not sure if, Joe, if you're in a unique situation, but if you felt the heat a little bit going back to Miami with these TAVR results.
Well, I'd like to say that TAVR is here to stay, but if you saw the recent sub-study presented at the AATS from the low-risk Evolute trial, it showed that the low-risk TAVR results were equivalent to those of the right mini thoracotomy. More patients with a right mini thoracotomy were discharged home, and less went to rehab facilities. Quality of life was equivalent. So I think we do need to stay relevant and have a competitive approach. I know in my practice, if I offer a patient a TAVR versus a SAVR, they just don't want a sternotomy. So I think for us to stay relevant, we need to have an alternative approach. And we need to continue to challenge ourselves to make the operation lesser invasive and also more, we need to make the operation more standardized. And that's the problem today, that it's very difficult to have a trial comparing right mini thoracotomy with a TAVR, because all of us do it in just a little bit of a different way. If we had a more standardized approach, I think that we would be able to have a trial that would show, I think, probably superiority to a TAVR, especially long term.
Well, I guess one of those questions, obviously, the long term, you're looking at, let's say, durability. I mean, is TAVR, I'm just being provocative here, is a TAVR valve less superior than a biological valve surgically?
Well, there's one thing that we, in a young patient, when you implant the TAVR, there's still calcium surrounding the TAVR. So as far as I know, calcium continues to grow. Calcium begets calcium. So eventually, it's going to be, you can have more calcium within the annulus. And on top of that, if the patient ever needed a redo, I think what we're going to need in the future is reference centers for removal of TAVRs, because this is going to be a big operation if the valve invades the mitral annulus, the aortic root. I know I've taken out one where as you start peeling the TAVR valve off the root, you end up with adventitia. So it becomes a full root operation, and sometimes an anterior leaf foot procedure on the mitral valve as well. So it's not as the answer of TAVR for young patients is really not is not acceptable for every patient.
Tom, which is your knowledge related to the impact of crimping on respect to other options? So peripheral is collapsed and not crimped. Other stented valves are obviously also not damaged by any effect of collapsing or crimping. Do you have any observation to do on this?
Yeah, I have some anecdotal knowledge. So first of all, I think that intuitively it seems like TAVR have lower durability, but it doesn't seem to be the case so far. We haven't seen any signals just yet, but intuitively it does. And the reason why I think is because of the crimping. I've had some drinks with some of the chief engineers at Edwards, and they revealed that the reality is the valves can be crimped to a 14 French size, but they can crimp it to 8 French size. They can crimp it as much as you want, but they know, and they reverse engineer it, and they decide, okay, well, if you crimp it to roughly 14 French for the balloon expandable valve, then that's probably the sweet spot that they're willing to tolerate so that you won't have any adverse damage to the tissue. So I do think there is damage to the tissue with crimping of the valve. There are some other options out there with valves that are collapsible, the percutaneous valve, which I think potentially might not have as much effect on the leaflet tissue. But I think undoubtedly crimping does affect the tissue and affect durability. But I think time will tell.
Sure. And Ansen, we also have in our introduction to speak about indication. You know that frailty is considered a indicator for addressing a patient to TAVI. Are you using frailty scores? How many of you are really considering this as a contraindication to surgery? Frailty scores.
Frailty.
A frailty score, I see here. So, we in our program, we actually discuss every single referral to a heart team setting. So we have cardiologist, surgeon, imaging guy, and very important part of that is the TAVI nurses. So we have them go through the whole assessment, including the mental status, physical, and we actually give them a frailty score. And actually they will recommend, the nurses will independently actually take a picture of the patient and then give us a frailty score and also their recommendation that should the patient receive any therapy. Or they will give them a green, yellow, or red to tell you that, should we look at that patient. And also, we also look at what's the prediction of a 2-year survival. And then we take in all those data and decided how many, because since we are in a socialized medicine, despite we do about 300 TAVR a year in our hospital, that we will still have to control cost. And we decided if the therapy should be offered. And that's, I think it's very important, I think, the frailty score. As surgeon, we use our eyeball test, which mostly accurate. By shaking hand, having the patient stand up in front of you, probably give you a good 80% accuracy of how the patient would tolerate any therapy. But for them to go through a more intensive testing of the mental and physical score is very helpful. And I'm sure the many centers, including ours, we publish on the frailty score. And I think that we also should adopt that to actually our regular surgical aortic valve, and also root out some of the patient probably, perhaps benefit from a less invasive procedure.
Frailty is such a tricky topic because it's such a vague term, and I don't think we have a consensus of what frailty is. And the score that we use, and a lot of it has to do with the original TAVR trials, are very subjective measures, right? Grip strength, walk tests, a couple of lab tests here and there. And what I've found is that a lot of cardiologists who want to push a patient to get a TAVR will say, hey, the patient's frail. And we all know that you can have a patient walk pretty fast, you have the patient slow down a little bit, and they'll fail the frailty test, right? So I'm not sure what the best way to get around that is.
I think a lot of the indications for TAVR are also modified depending upon what the physician wants. I think frailty is obviously something that as surgeons, as you mentioned, Anton, is an eyeball test, and with more experience, obviously that eyeball test gets keener and keener. But I think the high risk patient obviously will definitely benefit from a TAVR compared to the low risk patient.
Well, I don't think we're discussing if the high risk and also the intermediate risk patient probably are passé. I mean, they are all going for TAVR now. I think that how we can get a hold of and be meaning to prove that surgical aortic valve is still relevant in the younger low-risk patient, I think that is where we should concentrate our effort in. Even the older low-risk patient, I would say that is probably far gone. I think you have data to show that elderly patient, the cutoff, it could be 75 or maybe 80. Let's say just say 80. 80-year-old with low, whatever risk you calculated on whatever score you are, should just get a TAVR.
I want to get the panel slots, and maybe Arash and Gilbert out there as well. So right now we know that CMS is going to come up with some recommendations about TAVR requirements and what it takes to start a TAVR program. And one of the points that has been brought up, and it won't be brought up at this CMS, and it doesn't look like on the draft, but right now for a TAVR, a surgeon has to sign off for a TAVR, right? The counter argument is that in the future, a cardiologist should sign off for all the SAVRs that we do, which sounds absurd, but it doesn't, it's not too unrealistic. I'm curious what your thoughts are, and maybe Arash and Gilbert, if anyone in the audience wants to chime in, I'm curious what their thoughts are. When first time I heard it, I thought that's the most silly thing ever, and I still think it's pretty silly, but I think there might be a point to that.
Yeah,
thoughts?
I disagree. I mean, I think the surgeon should control the environment. I think if we do that, we're handing everything over to the cardiologist. So I think we should still stay in control.
Yeah, well, we don't have that requirement in Canada. Obviously, we do not have, because the funding doesn't come that way.
It's not like that in Miami either.
And it's not you don't have to have both presence to. However, despite what you said, the gatekeeper is actually cardiologist, not us.
Well, it depends. So, I agree with that, but I think it depends on how you structure your practice and how you build what you have, because maybe my practice is unique, but I see most of the aortic cases first, and for lack of better words, I'm the one that helps decide, where the traffic goes. So it's a unique, but I think we each need to build our practices structured around valve surgery and valve therapy. So if you do that, you will probably be the gatekeeper most of the time.
That is a bit, your situation is a bit, different from the rest of the world. I mean, you might have that scenario in some Asia countries still, and maybe in some European country that might still control or have a gatekeeping role as surgeon for those cases. But I think most of the world that cardiologists are the gatekeepers. And if that you turn to, as what Tom said, so they have to sign off for surgical aortic valve, we'll have no valve. We've been doing absolute zero aortic stenosis patient.
So I'm living in a hospital where the cardiologist is telling me that he don't want to discuss anymore the low-risk patients because there is no reason to discuss. It's low risk, a good indication for TAVI. So we have to discuss only the high-risk patients. So what is your vision in this? So discuss high risk because this could be possible candidates for surgery, seeing that they are at high risk also for TAVI, because high risk for surgery means also high risk for TAVI. So what is your...
Well, I guess it depends what you call high risk and low risk. I think this is what the definition is. Is it high risk purely because the STS score is high? Is it high risk because it's anatomical reason is high risk for whatever surgical or TAVR of left main, subvalvular calcium that you could get rupture and things like that. So I don't know if you could just use a blanket statement and say this patient is low or high risk for certain therapy. At least in our system that we are reasonable because we have to look at resources. And we cannot just go suddenly tomorrow, despite ACC came out, we say that tomorrow we will be no surgical aortic valve, we'll be just doing TAVR. That would bankrupt our system. And we are reasonable. We actually look at the data ourselves, despite we are one of the one of the center-driven all this to begin with. That we have to look at it and say, well, is it reasonable? Is it evidence-based to go to low young patient? Which we say absolutely no way, and we're not doing that.
The other thing to consider is that you're saying that the cardiologists say that there's no discussion on the low risk, but on the contrary, there's, in my experience, a lot of the low-risk patients, which are the young patients that have bicuspid valves, very extensive left ventricular tract calcification, which in the current trials were excluded from them. So, and also aortic pathology as well. So a lot of those younger patients have more extensive disease that is not addressed with these low-risk trials.
Which is for you still the role of full sternotomy? Do you see an indication? You are the right person to ask.
No, I mean, I actually, have been a big advocate for many years now of doing non-thoracotomy surgery. I'm an advocate of saving the sternum, not splitting it. And again, as I mentioned earlier, I think if we have more of a standardized approach, for years now, I'm no longer transecting the rib. It's with just a slight rib spreading. So I think if we standardize the approach, and you very well know as well, that I think the results will continue to improve. And I do think, again, if you want to stay relevant in cardiac surgery, you need to do not a hemisternotomy, not a lower sternotomy, a right mini thoracotomy.
Tom, which is the role for the stented valve in future?
The stented surgical valve?
Yes.
I think there is some potential with, especially with the minimally invasive approach. Again, when talking about the various stented valves or the collapsible valve, I think there is some at least data to show that might have at least better durability than a valve that is crimped and collapsed. I think ergonomically, it's obviously a lot faster and easier to use some of those valves. But
I think a stented, the Percival valve to me is the easiest valve to implant through a right mini thoracotomy, and it takes away a lot of the fear of not tying, if that's one of the issues you have. But I think it is the easiest valve to implant, and maybe that's the way you should start with that, and then grow to using the stented prosthesis, where you have a little more complexity in tying the knots and delivering the valve. Although it's not for every patient as well. There's certain contraindications.
And looking to surgical indication in younger patients, which are the limitations or the vision for valve-in-valve? So which is the target of age for considering a biological valve, even in respect of the size of the annulus, since that we know that TAVI in small annulus has impact on durability and survival in the small annulus?
Well, again, I guess you cannot just use again, young patient, what is the young age? I think that you have to look at the patient, what is the life expectancy of the quality of life of the patient should be, you should look at. A 60-year-old who have multiple comorbidities and don't think that you live long, a TAVR may be the option. However, if someone who's really healthy and robust, and the longevity could be 30 years, a TAVR probably is not the right answer for those patients. Now, let's say that you do a surgical biological valve in that patient. Is it the right answer? I'm not so sure. I mean, you look at that, I mean, how, all those patients that we take back for now redo biological valve or valve in those patients, a lot of those young patients, and they will have I think we were overswing the other way of doing too many biological valve for young patients. And if for full patient who are well educated, have proper home monitoring of INL, a mechanical valve may be the option and give you the longest longevity. Mm-hmm. And then just the last thing about the valve in valve is that there's a lot of problem with valve in valve. First of all, the longevity of those valve in valve, despite the original surgical aortic valve are big enough to allow you to have low gradient in those patients, they have problem with thrombosis. They have problem with much lower durability. And obviously, when you eventually have to do redo on them with 2 to 3 stacks of those valves are not pleasant to do. None of us had answers for that, but those are the things that we need to look at.
I'd like to make a point about that. So in my practice, the majority of patients will choose a biologic valve for obvious reasons. They don't want to be on Coumadin. But one thing I think is, as my practice has evolved throughout the years, I see redos on the minimally invasive cases. So those could be a little bit challenging. So I think that first of all, if you start off with a right thoracotomy and the patient requires a sternotomy, the pericardium is intact anteriorly. So it's almost like going into, so there's no a primary chest. So you don't fear entering the ventricle. But what I've been doing lately, especially in the young patients, is I use Seprafilm. I don't know if anybody have had the experience, but so I operate on a young patient, I'll place Seprafilm medial to the lung, lateral to the lung, near the chest wall. And if you have to reoperate on these patients, miraculously enough, it's almost like the first time operation. So I think the more and more we do this, we need to plan for the future, because if you think someone else is going to do your re-op and it comes back to you, it becomes a challenging operation. So you need to prepare the patient for the second operation.
Tom, which is your approach in a patient with aortic valve and single or 2 vessel disease? Do you consider a hybrid procedure, minimal invasive surgery, and PCI stage before, after?
This is, I think, a good question. I think it's a chance for us to collaborate and work with the cardiologists. My approach is very similar to Joe's. I do almost all my AVRs via right thoracotomy. And in this scenario, depending on the lesion of the coronaries, I would actually push for a PCI. The next question is the timing of it, whether or not you do it before or after and with the patient on Plavix. I personally haven't found as much of an issue operating on Plavix if you operate on Plavix personally. So in a scenario with some precarious coronary lesions, my inclination would be to have a PCI, wait a couple of days, do a right anterior thoracotomy on Plavix.
Well, I think as time goes, I think we all have a different perception of coronary artery disease in those patients with aortic stenosis because of the TAVR. Is we largely ignore non-LAD, significant LAD lesions. And I've been doing is to not bypassing them for non-LAD lesions. I'm just doing a mini aortic valve and leave those alone. And if the patient come back with symptoms, or other parameter that think that ischemia persists, then they will get the PCI after, not as a standard.
Yeah. My practice has always been doing the PCI first, and it's spaced out. We've actually published a study looking at 222 cases that we did early on, and we waited between a few days to a few months to do the minimally invasive aortic valve operation. And there's the only difference, I think, operating on Plavix is not a big issue. I mean, obviously there's some responders, some non-responders. the incidence of transfusions have been very low, especially, platelets, fresh frozen, other factors like that. But I think if the patient's on Brilinta, that's a little bit different. If they're on Brilinta, I'll stop it and I'll place them on Plavix. I think Brilinta is a much more aggressive drug and the risk of bleeding is a lot higher. So I will, convert them over to Plavix. I think that's an important point.
So my approach is if the patient is asymptomatic for angina, independently from the number and coronary artery involved, I do aortic surgery first, and after I do PCI if necessary, based on a FFR study. And here FFR surely plays an important role. Obviously, FFR can consider it even for very critical lesion before, or at least angiographical lesions, but cardiologists are not happy to do FFR in a patient with aortic stenosis. So I prefer to do valve surgery before, because most of the times the patient is referred for aortic surgery.
The only problem is if they fail the PCI after you did the surgery, then that becomes an issue.
Obviously, the cardiologist has to tell me that it's a suitable, easy, low risk of restenosis in his hand. If he says, no, it's not a nice lesion, let's do it first, but it's quite rare.
The other subset of patients, which is interesting, is the patients with a totally occluded right coronary, where you could easily bypass the distal right. The PDA is a little more challenging, but you could bypass the distal right. The only technical trick I could tell you is that if you do a bypass to the distal right, you need to start off with the toe of the anastomosis as opposed to the heel, which is contrary to what we normally do. So it is a little bit different, it's a little challenging, but definitely doable.
Yes, I don't have experience. I did only one case, but...
Actually, I have an interesting, since the audience here, I haven't heard from them yet. This is largely, audience of less than 60 years old, except maybe many. Let's pose a question of a show of hands. Let's say you have aortic stenosis with no coronary artery disease, no other valvular abnormalities, and needing an aortic valve replacement. Would you have a TAVR or surgical aortic valve? So TAVR, hands up, please. Well, we have a surgical group, I guess. Well, no, it's okay. There's nothing wrong with that. Okay, so it's very little. So let's say, largely you want a surgical aortic valve. Would you want a biological valve or a mechanical? Let's say biological, hands up. Wow,
Who wants mechanical? Anton, you want a mechanical?
Well, I think I would, even though I do all this mountain biking and all these stupid things that I do, the jump off cliff and snowboarding, but I still would. I would do a mini, obviously, I think that. Well, you want a surgical, like a full sternotomy versus a more or less invasive aortic valve? We are in the East mix. But anyway,
I would extend that. So,
but I would just maybe pick on someone who actually picked a biological valve, surgical. Can you someone just come up and tell us why? Come on, some volunteer.
Andy, you want to do a consideration?
Sure.
Karen Gersh, I actually have, oopsie daisies. This was a question I was going to ask you. I have two questions. First one, it hinges on that mechanical. At what age do you say I promote mechanical valve versus a biologic? Which is a real, I've got a 36-year-old, I've got a 45-year-old that has horrible bicuspid aortic valve who needs an aortic valve replacement. What do you tell this roofer who works in Charleston on the tops of houses? These are real conversations. So what's your age cutoff for mechanical versus biological? Now, my 65-year-old, I do minimally invasive aortic valve. I'll do that, no problem. I'll do a biologic. But when do we say mechanical is appropriate? What's your thoughts?
To me?
Any of you guys. Because this is we all sit in front of these patients and we don't really know what to.
I think that less than 40 is surely mechanical. Over 40, I inform very well the patient on all the options, even repeat up to 2-3 times for surgery, and then the patient has a right to choice. But up to 50, I try to address him to mechanical, but between 40 and 50, I want that he is well acknowledged on the possible scenarios that he can have with the two different options.
Are you, because I kind of shoot for that 50 also. Is that kind of what you guys look
No,
at?
I have a discussion with the patient, and I let them make that final decision.
Yeah, well, we all have discussion, I guess, but you always sort of biasing or steering the
That's
patient
right.
to certain things. And my cutoff is a bit higher. I think 60 is what I usually do. I mean, I won't tell them that's what they should have, but 60 is where I think, even though that you think the patient was like the roofer with higher risk occupation, I'm not so sure the risk is that high. For being anticoagulated. And then versus we do, we whatever that you do for valve in valve, for valve in valve, valve in valve. Though the procedure itself is low risk, but the complication rate and then recurrence of event is actually much higher in those patients, especially if the patient has small surgical valve to begin with. A valve in valve doesn't solve the problem.
I have a second question. I have a 72-year-old lady who I'm doing a minimally invasive peristernal aortic valve who has an STS risk of 1.376. She had been seen by the 72, almost 73. She had been seen by my cardiologist beforehand. He had her all geared up for a minimally invasive, for a TAVR. And I sat down with her and said, well, what age are you guys looking at? I mean, I know each patient's individual. There's some 72-year-olds who have a STS risk of 12 and some that have 1.2 something. Where do you bias yourself with these patients, 72, 75, 70, active lady who's like, doc, I don't want to have a big surgery, and here's why. I got to play tennis, and I've got to go to downtown Charleston, I've got to do. But when do you say, well, look, you're 72. Do you guys look at a hardcore age? I mean, and the low risk patients, not intermediate or high, that's a no-brainer, but low risk.
No graft?
No graft. Straightforward aortic valve.
Yeah, and size of the aortic valve?
She's good. We already did TAVR. She would be a 26 S3. So I don't need a root enlargement. I don't need any of that. So
for us, it would be a TAVR. I don't think that, I haven't, unless the patient is in the trial, I don't calculate STS scores.
yeah.
I think it's completely irrelevant. STS
For us, it would
scores.
be a mini AVR. I mean, I think I would look at the patient as opposed to the age. I think that's important. And I do mini AVRs on patients in their 80s. But it just depends on how the patient looks and what comorbidities the patient has.
Well, I would also do a mini
much
AVR
cheaper.
on that patient as well.
So the reality is that when the low-risk trial was presented in ACC just the evening before they lifted the embargo, which is kind of unusual, and I just want to bring that to the audience here. The next morning, and I was there, it was a fantastic crowd, as usual, a large crowd. When the low-risk trial was presented, I looked at the podium. I always look at who the moderators are. It was the ACC president, and then next to him was the associate editor for New England Journal of Medicine. I had never seen such a blatant violation of conflict of interest for a New England Journal of Medicine associate editor to be in the moderator. As soon as I finished listening to the talk, I have so many emails and texts from my former patients and who has relatives and my friends. Suddenly the New York Times have published that thousands and thousands of patients do not need any aortic valve open heart surgery anymore. So I think there's the problem. The problem is Anson, and all of you leaders are there. You may have some clout, in the ACC or AHA, but this has got to stop. That is the problem we have. How do we message? How do we get the conflict of interest and honesty, ethical conduct of any presentations to be publicized? So until we get rid of that, we can discuss all you want. The cat is out of the bag. So
We need to make Jagger dancing for surgical aortic valve.
So we need to conclude. I thank you all speaker and audience for this interesting session. So now we have the next session on mitral versus mitral clip. We have Tom. you stay on the podium.
Hey, how are you? Good to see you. Yeah, there's.
Is Lino here?
No, he couldn't make it.
We should keep the program going. Maybe 15 minutes behind. And do the coffee break.
We'll go and get started. So the theme of this master section and master indications is to really dive deep and understand the indications for, as you saw at the beginning, CABGs, PCI, in the last session, minimally invasive surgery, TAVR, and then the next transition, which we'll be leading and discussing, is TMVR, MitraClip, minimally invasive surgery, and sternotomy. I'm privileged to have a very esteemed panel here this morning, Dr. Gilbert Tang, Dr. Randy Chitwood, Dr. Thierry Massana, and Patrick Perrier. And we're going to talk and dive deep about the indications for all these mitral procedures. I wanted to start, and again, I want to encourage audience involvement. If you guys have any questions you want to bring up or experiences, please feel free to walk up to the podium. And this is hopefully should be an engaging session. I wanted to start off with just a quick summary for many in the room of the various relevant MitraClip trials. Gilbert, can you give us a 1 or 2 minute summary of COAPT and Everest? And those are probably the most relevant trials that we should probably know about.
Well, I would just start with a very broad stroke. So MitraClip, this is an international audience. It's been available in Europe for much longer. It's been around over 15 years actually when the first implant was done. In the United States, the MitraClip was approved for primary MR in prohibited risk patients in 2013 or 14. And most recently, in March, it's now approved for patients with secondary MR who are not surgical candidates. So that's kind of the timeline, how things have evolved with at least MitraClip. It's over 5,000 implants have been done. The initial approval was predicated on people basically who are not surgical candidate, extreme risk, and they randomized the patients in the Everest 2 trial between MitraClip versus mitral valve surgery. And certainly the safety profile of MitraClip with a percutaneous venous access was superior to surgery, but there was higher recurrence rate of mitral regurgitation, and we know that recurrent MR is bad for the patient. So, but at the end, they still got approved because mostly of the safety profile. Now, fast forward to 2018, now secondary MR with basically medical management is still the gold standard, but now a lot of transcatheter mitral devices are now on the horizon, and MitraClip certainly has been used in Europe for a long time in secondary MR. And there were actually 2 trials, randomized trials that were published in New England last year. One was called a MitraFR, which is a French study randomizing patients on medical therapy versus MitraClip plus medical therapy, and found to be no different between the 2 therapies at 1 year in terms of outcomes. On the other hand, in the US trial, which is sponsored by Abbott, they also do the same thing, but they're a little more vigorous in terms of screening patients out. Where they have to be on maximal tolerated medical therapy, so they can't just be on Lasix 20 milligrams once a day and as medically optimized, they'll be on a cocktail medication. And when they randomized it to MitraClip, they found that the MitraClip was actually had a reduction in mortality and rehospitalization in 2 years. So based on that, we now have a better framework in understanding where MitraClip fits in heart failure patients. These are basically heart failure patients, they're not patients with primary MR. And we find that there are patients who have a lot of MR, but the ventricle is not at the end stage in terms of dilatation. And these patients, called disproportionate MR, are the ones who will benefit from MitraClip. So that's kind of in a summary what that means. Now, I think from this audience, how is this relevant? Well, I think we need to be involved in transcatheter mitral therapy because we do surgery very well for primary MR. Secondary MR, I would say so-so based on New England Journal randomized trial. But now we have all these catheter therapy that we can offer to these patients, And we don't want to be like the situation where the previous panel said with TAVR, you're going to have to get signed up by a cardiologist to do surgery. We need to have a more heart team approach, and this is still its infancy. I think that's where we surgeons can really participate because we know the mitral valve probably better than a lot of our cardiology colleagues.
So as a summary of the trials, I want to open up a question to the panelists. What were some of the weaknesses of the COAPT trial or some of the MitraClip trials? What are some of the things that it didn't address?
Well, one thing it didn't address, degenerative disease. These are functional disease patients, and also, yeah, I think that's one of the biggest things. I mean, you know, most of our stuff that we're operating upon is degenerative disease.
I think the COAPT trial is again a trial that has been sponsored by industry. So the selection of patients was extremely strict compared to the mitral FR trial, which is also a CLIP trial in France. And I think the results were not as favorable with the mitral FR, although the patients, I believe, in the mitral FR reflect better the real-world population. So when you look at the results of the COAPT trial, they are excellent, and that will probably generate an explosion of mitral clip into the functional MR. But as Randy was saying, it's just about functional MR.
Well, two things. I think that we should be suspicious, maybe, when you have some randomized trial, which are controlled by companies. And amazingly, between the French and the COAPT, one is controlled by the company and the other one is independent. And amazingly, the results are different and in the way that we could foresee. So this is one thing. Second thing, I think that we have to admit that surgically we are not good for functional mitral regurgitation. And there are many patients with functional mitral regurgitation that are denied treatment, and MitraClip may be a solution for, or is so far the only solution for those patients.
I guess the question is also, Tom, we know the NIH studies, at least at the 2-year mark where you put an annuloplasty ring in for functional disease, we know that 50% of those patients are leaking. So the question is, does this totally put us out of the way for, or dismiss surgical repair for functional disease versus the MitraClip?
So I think the problem I have with this CTS trial, it doesn't compare mitral valve replacement with tissue valve versus mitral valve repair.
No.
It does compare with undersizing annuloplasty, which is one technique of mitral repair. So I think that's the main pitfall, in my opinion, of this trial.
Well, that's when it comes into the question of clip versus percutaneous mitral, and I guess we'll get into it, mitral valve replacement.
So part of MitraClip, the patients are required to be prohibitive risk, and a little bit different than aortic valve. We have at least an STS score to lean on a little bit. Prohibitive risk is even more of a vague term that I've seen, and I've seen cardiologists throw around that term very loosely. How should that be defined? Gilbert and the rest of the panelists?
The FDA does have actually STS score for primary MR in MitraClip indication. It is STS score repair for over 60% or greater and replacement 8% greater. So there are actually STS scores. So I think one of the things that we haven't done a good job in is to actually get involved in MitraClip in these type of patients. So when you have a team discussion or you have a patient discussion, you're very transparent that I do both. I can give you either surgery or transcatheter therapy, but I believe here's the data and here's the hear the pros and cons. And just like TAVR, that's what I do every day. I told them a 65, 70-year-old wants to get a TAVR for low risk. I said, well, you have these other caveats you need to consider, and then ultimately it's the patient's decision. But I think there are very clear indications of primary MR. Secondary MR, I think, is a little bit more vague. If you look at the FDA indication, there's no surgical risk involved because these patients, when they were in the trial, they did not have any STS score involved. They just say they're not a surgical candidate because they have heart failure and secondary MR. So that's going to be more interesting about how surgeons will be involved in the secondary MR space. But primary MR is still a very, very clear guideline. If you don't follow the guidelines and you get audited, you are at risk. But I think it's very important for the surgeons to know the data, know what the indications are, to have a proper discussion, and also especially the anatomy. So I'm not sure how many surgeons in the audience, when they ask to evaluate for MitraClip, even actually look at the TEE to make sure it's a clippable case. I mean, you really want to make sure you have a honest discussion, say, well, based on this anatomy, you would expect you have an MR reduction down to moderate, or maybe moderate, severe, or maybe mild or trace. So it really depends on what we look at, and I think that's really where the surgeon's role in these therapies will be. You're not just checking out, okay, this patient is not a surgical candidate, go do whatever you want. It's like, what is the best therapy for this patient, regardless, and you have to be very agnostic about it, because as surgeons, we tend like to operate, but I think sometimes we even tell them, you're doing fine with medical therapy, you're 95-year-old, just go enjoy a cup of tea.
What do we know about clip versus surgery in low to intermediate risk patients?
Any comments?
I don't, other than the Everest initial trial, we don't have many patients with low risk comparison. So that's the paradox of the clip. The initial trial to launch the technology was made on many patients who were low risk, as opposed to TAVI, where they started with a high risk. So the issue with the low risk, all these patients are young, and the Alfieri technique has proven not ideal technique for these patients with mitral valve prolapse. When they were young, you don't address the annular dilatation. There's many things that you don't really do. However, I must say that because of the publicity to the mitral clip, maybe not in Canada, but I'm suspecting that in the States, you start seeing these young patients with a P2 prolapse who just don't want to have surgery.
I think you're seeing this in Europe. I think you're seeing, a lot of degenerative disease patients getting clips that could easily be operated upon. You might want to comment, Patrick, because you live there.
There are some interventionalist cardiologists who are very aggressive, and they just can't resist. It's like this. Whereas we know, we don't know, but we can see that a patient with a prolapse of P2 who is denied surgery, which will ensure a very long and stable result and a normal life, and has a MitraClip with the risk of residual MR and of surgery after this. And surgery means most of the time valve replacement. And I think that this is a decision which has a lot of consequences.
I think this is an important question. I'd be interested to see what my senior colleagues here would say. The intermediate risk mitral clip randomized trial is coming in the U.S., actually. Pat McCarthy is the national co-PI on the surgical side, and Sabo Carr, the cardiology side. The more appropriate question to ask, I think, is which patients should be randomized, right? In terms of what anatomy should be is randomizable. Because obviously surgeons be heavily involved in this trial because it's going to be a surgical arm. I mean, that's probably a more appropriate question, because ultimately that's going to determine in terms of the whole landscape of treatment of primary mitral disease anyway.
Yeah, it's going to be like partner 3. Yeah. I mean, basically. No, I agree. But one thing that's a bit of a problem in the United States is with the clip, you don't have to have a surgeon, correct?
Correct.
With TAVR, you do have to have a surgeon. Now, in my place, since at that time I made the rules, I said this is multidisciplinary, we work together and all that stuff. But in a situation where if it shows that at 1 year, then intermediate risk with degenerative disease does as well with 1.5 plus MR as surgery as far as function, that doesn't tell me anything about long-term. I mean, how can you say, put it up against Tyrone Davis' data and others' data of 20 years of information with a very low reoperative risk? But you know what's going to happen. I mean, basically, it doesn't matter what, I mean, it's the coronary stuff. You know, you can prove every day that it's better than a PCI, but they still get done. So I think this will show, if it shows at 1 or 2 years, equivalency or some sort of semi-equivalency, it's going to open the gates.
I'll add to that a little bit. You know, I think it's really important as surgeons for us to recognize that the COAPT trial was very, very highly selective. 63% of patients were excluded. The average EF was 35%, and the age was in the 70s or so. So we don't know, we have no data regarding lower risk patients. And that's what we should use when cardiologists try to put a clip on a patient that is very easily repairable. Dr. Subramanian.
A couple of things I get from the listening to the recent trial and the latest data from the mitral clip in the Euro PCR is clearly if you get to the TERS house of 0 and 1 and 2 plus and 3 plus and 4 plus after the mitral clip, this is the COAPT, post-COAPT analysis. Clearly that 2 plus is terrible, 53% death and hospitalization, 73% in 3 and 4 plus. That's one fact. The second fact is that in spite of a huge need, whether we believe the population is 1.6 million or give or take 800,000, it's still a large population. But if you look at the global clip utilized so far, it's about 70,000, which just tells you something that there is a tremendous amount of room still for mitral repair in functional mitral regurgitation, whether it be surgery or different techniques or simplified, better results, or other catheter therapy. So I think it is not over, but I will caution you that, as Randy said, it is the coronary revascularization de joie because TAVI started with the inoperable group, high risk, intermediate, you know. So it is going to come, you know, whether we like it or not. But I think to be involved, Gilbert, is the whole question is, are you trying to tell you we are to own the turf or sit over the turf and decide which pathway to go? Because if you say you want to own the turf, that is going to be a real black hole because you can't say everybody's going to put a mitral clip because most interventional cardiologists and surgeon team do not let everybody to do the mitral clip. So you can't assume that every surgeon is going to putting the mitral clip. It's not possible. So you got to figure out what is that exact role we should have. Maybe come up with the new concepts, hypothesis in selection of patients, and offer a better surgical therapy. We do not have a good surgical therapy. We have not done any innovations in secondary MR in the surgical circle.
I just want to remain, I don't want to be under the turf. You know, one thing is, what about the COAPT trial now versus, all right, so you got the COAPT trial. It says everything's good. Then you've got people spending billions of dollars on percutaneous mitral valve replacement. So doesn't that dumb down the TMVR? Because basically only unless you've got really bad displacement of the papillary muscles, doesn't that decrease that market as far as putting in percutaneous valves?
I think actually the COAPT trial is the door open for transcatheter mitral valve replacement as well. I think what's going to happen is because in the real world, the mitral clip technology will develop with less strict criteria than in a COAPT trial, and then the real results of the clip will open up. And so in 5 to 10 years from now, the results, the discussion would not be surgery versus clip, would be clip versus TMVR. And this is already heading that way.
But in the younger patient with functional...
FMR.
Yeah, with functional disease. So you got a young patient with functional disease, youngish, 55, 60 years old. We know you're putting this big rag in the heart. I mean, you go back and look at some of the early prototypes back in the 50s and stuff from they're big rags. So you know you're going to have to anticoagulate that patient. And with the clip, you're not going to have to anticoagulate long term.
Well, actually, we do anticoagulate many of the
Long
clips.
term?
Some,
Coumadin?
some of these patients are just sick and they have other reasons.
Or they're an
for
AFib, yeah.
anticoagulation, so.
Yeah.
I wanted to bring up a couple scenarios and get the panelists' thoughts on how they would approach this particular patient. 82-year-old woman, severe degenerative MR with P2 prolapse, chronic kidney disease, stage 4, EF of 40%. We'll just go down the panel and give us your thoughts on what should be done for this patient.
No, I think depends on which center you're at. Some people actually, some centers, this patient may get operated on if it's a repairable valve. I think really what your goals and objectives are on this patient. Is it quality of life, or are you going to try to restore the patient's life expectancy, which in 82-year-old probably won't be the case with a CKD4. So I think it's anatomically suitable. You're going to give the patient a discussion saying, if this is suitable, we can tap mitral clip. You may get down to mild MR or maybe mild moderate, depends on the anatomy. However, we hopefully will benefit you from a quality of life and symptom improvement standpoint. That's what we're going to try to do. And we also have to look at whether they're optimized or not. I mean, they may be not on any Lasix coming with MR, and with maybe one hospitalization with flash pulmonary edema, say we'll start them on Lasix, they feel great. I don't want to hurt the kidneys. I mean, even though this mitral clip doesn't involve any contrast, and we might not do the intervention right away. We might see how the patient does in return. If the patient is symptomatic, then we can consider. So again, I think we need to be very thoughtful about what to do with each patient. I mean, like I said, at least in my practice and our program, we don't just go ahead and book the case tomorrow or next week. We're actually very thoughtful about saying, have the patient been managed properly? And we often talk to our cardiologists, say, hey, we saw this patient and we felt that maybe try some diuretic therapy or some other medical therapy. We can reassess in a couple of weeks, because ultimately we know where the patient's going to come to is probably going to be some kind of intervention. But to just say that, okay, the pictures look good, let's do it, it's I think a little bit of a kind of a hammer and nail approach.
Dr. Chitwood.
Yeah, this is in the 20% discussion group. We're basically 80% you kind of know what to do, and 20% you don't know what to do.
Right.
So this is when you sit down with the cardiologist. First off, I caution people about referrals. When people refer you patients, especially if you're at a large center where they're sending you echoes from everywhere. Because I had two cardiologists who would send me patients with severe mitral regurgitation, central mitral regurgitation. And they were hypertensive. The Nyquist values were totally off. And of course, how do you, without, pissing the guy off that's sending it to you, you say, I got him down there and I did a little bit of echo work and the echo machine made him better, so let's follow him. So that's one thing. In this patient, let's say the patient's on dialysis. And was this patient on dialysis?
No dialysis.
No dialysis.
Surgically,
surgically can fix this valve with mix. Okay, you can do that. If they're not on dialysis, you do run the risk of putting them on dialysis if they're 4, something like that. So I think you have to come down and is it a flail or just a prolapse? If it's a prolapse and a little bit of prolapse, and even with severe mitral regurgitation, you're probably going to be better if you could treat them medically as well as with a clip. But the key thing here is, are you going to put the patient into dialysis land after the surgery? And I think that's what we're going to have a tough discussion. So I think it's going to be between a clip and a mix.
Robot mix? Robotically or?
Well, that's what I did, man.
Okay, fair enough.
I mean, to me, that is mix. I got tired of doing mix. I did 600 of those before I did the robot stuff, so.
Fair enough.
So for us in Ottawa, I believe all these discussions depend on the microcosm and the environment. As having the honor and the privilege to be the CEO of the organization, there is absolutely no transcatheter valve therapy which is not done with a surgeon and a cardiologist from the very first case 12 years ago. So what would happen in this case, I'd tell you, is very simple. It will go to the mitral clip team, and I bet you 90% it will be a clip, and the surgeon will probably do it with the cardiologist.
Yeah.
Yeah, this would also be our probably our strategy. Carefully analyzing the patient and carefully looking at the anatomy of the mitral valve to see if the mitral clip would be a good option with the good results. Because if the patient comes to surgery afterwards, again, it's not a good solution. Discussion again.
Just want to get the audience thought. So what would the audience do? How many would do a full sternotomy on this patient? How many would do a minimally invasive via thoracotomy? It's a very easily repairable valve, I think. What about robots? And then how about clip? So you're right, it is a 20% group, so there's a lot of division in the room. I'm going to end with one last scenario. 75-year-old woman, COPD, EF about 45-50%, severe MR, again, let's say P2 prolapse, flail, and an EF, and she has coronary disease that is a focal stenosis of the LAD, mid-LAD.
So you got an LAD lesion too.
She has an LAD lesion as well.
So your options, well, it depends on how bad the COPD is. I mean, if they got an FEV1 of less than 1 liter, that's one thing. As far as going through the right chest and putting an aortic valve in, and then doing a mitral clip or some sort of hybrid approach. If it's not that bad, I'd probably do a sternotomy just do it. I mean, there is a place for sternotomy. But talking about a TAVR versus a TAVR clip option, if they have absolutely terrible COPD, and then see how bad the LAD is with FFR. If it's 50%, leave it.
Gilbert, Dr. Mazzano, Dr. Perrier.
Well, I think it's probably a little bit more complicated. I would say it would really depend on the team discussion and probably the patient. I think at the end of the day, the patient will probably have 2 options and will decide. The problem that in our world now, the patient, even the old patient, actually, they surf the internet as well as any young patient. They know, they come to the hospital, they know you, they have Googled you, they know what you have done, they know who is doing this in your hospital, and if the old person doesn't do it, the children will do it for them. And this is what happens. I mean, then they come and they already have a lot of questions. They are not discovering the technology. So I think you have to be prepared to face this with the patient. So the patient is more and more the owner of the technology. My last comment personally is that all these questions will never happen if the surgeon really involved in this technology and own it. When I say own it, I would say co-own it. But it's the fear of the surgeon in this technology is mostly happening in centers where there is a fierce competition, where the surgeon may lose the practice. So in centers where the surgeon were able to control or to direct the practice, these discussions are easy.
Any final thoughts?
I agree with Thierry, but I would say that is it because you lose business, or is it because there is a financial consequence for your department, for you, regarding your decision? I think that it is important. So I think that probably if you are organized in a way that the financial consequences may not impact your decision, it's probably the best, because you can do things only for the patient's benefit.
I think we were the first to, and correct me if I'm wrong, but I'm almost sure that we were the first to form a Department of Cardiovascular Sciences, where we pull cardiology out of medicine. That almost got me assassinated. And we pull surgery, cardiovascular surgery, and thoracic surgery and vascular surgery together in one department. So therefore, you have a common economic interest. Also, you can say, you set the rules. You say it will be multidisciplinary, that everybody will be involved in this stuff. And of course, a place like the Cleveland Clinic, they can do it not as a department, but as a company policy. So, and if you don't learn these skills, you're toast. Especially if you're a young surgeon coming along. You better get yourself to a place where you can learn these things.
I'll conclude with my thought, and Gilbert, and I think others in the room is I think we should be less inclined with defining ourselves as surgeons and cardiologists, but be more disease specific and disease centric, and as valve specialists that can approach valvular heart disease, coronary disease, and all the different methods possible, whether it be sternotomy, minimally invasively, or by wire. Again, I want to thank the panel for an excellent discussion. I thank the audience. We have a break now until 10 a.m. And we will start our next session. Thank you.
Good session.
Good, thanks. Thanks, Carl.
Good.
Great. Thanks. I'll see you this afternoon. Yeah.